first session, the opening session will be, it's entitled From Technical Skill to System Safety, How Can We Prevent Harm in Regional Anesthesia in the Modern Practice? So safety in regional anesthesia is paramount to our practice, whether from technical problem to image quality or drug dosage. We have to be very meticulous, and also we have to introspect ourselves how we can mitigate or avoid these problems. So this session is aimed at going beyond the dogma on to focus on how modern regional anesthesia fails, but how to look at it from a systems perspective to make it more. So the first topic will be entitled, How Can We Prevent Wrong-Sided Block? The second topic is how to deal with post-operative neurological symptoms when blocks go wrong. And the third topic is even more apt for the current practice because technology can create its own set of risks. So how ultrasound, AI, and all those newer technologies can create an illusion of safety and how to deal with it. With that, I'll give back the stage to Raj.
So our first speaker, Uchenna Umeh, is going to be talking on the topic of wrong-sided and wrong-site blocks. Uchenna, I'm just going to let you introduce yourself and start your presentation. I've got your slides up on the screen, and we'll take ourselves off and let you continue the presentation.
Perfect. Raj and Rakesh, thank you guys so much for the opportunity. I really appreciate the time. So I'm Dr. Uchenna Umeh. I'm an anesthesiologist at Hospital for Special Surgery, clinical associate professor at Weill Cornell Medicine, and I'll be talking today about prevention and management of wrong-sided and wrong-site blocks. So for the learning objectives, I'll identify the key risk factors for these blocks. I'll describe a robust verification process and how to apply evidence-based prevention strategies. And then we'll discuss some system-level contributors and how to manage and report these blocks appropriately. So wrong-sided blocks are considered, and wrong-side surgery are considered never events, right? The Joint Commission defines wrong-site surgery as an invasive procedure performed on the wrong part of the body, wrong site, or the wrong patient, thus exposing them to more than minimal risk. And this definition encompasses procedures that are done both in the operating room as well as outside of the OR. And as I mentioned, it's considered a never event by the Agency for Healthcare Research and Quality, and also in the UK by the National Health Services Healthcare Safety and Investigation Branch. So it can cause patient harm, loss of trust, and has medical legal implications. And despite all the guidelines and checklists, it still occurs. And then the last thing I wanted to point out is it does have a profound emotional and professional impact on the clinicians who are our second victims. So how do we define wrong-sided block? What do we mean when we say that? So a wrong-side block is defined as the correct procedure on the incorrect side, and a wrong-side block is incorrect anatomical location. And of course, this can occur in perioperative regional anesthesia as well as interventional pain procedures. The incidence varies depending on the institution, but it can be as frequent as 7.5 per 100,000. I used two institutional data on the tables you can see here up on the right side. I first looked at a study that was published at University of Pittsburgh Medical Center, and they looked at their institutional data from 2003 to 2012, and they examined about 70,000 patients who received only unilateral blocks. And in their institution in that time period, over that time period, they had 9 wrong-sided blocks, which gave them an incidence of 1.28 per 10,000 patients. The incidence of wrong-site block in their data was highest amongst femoral blocks, and it also differed from the incidence of wrong-site surgery, which was higher. They did mention in their paper that all occurrences of wrong-site block was after the implementation of their timeout policy. And so they all involve policy violations. The second table below is actually from my institution at HSS. Greg Ligori and a couple of other colleagues published our data from 2003 to 2016. And they looked at the incidence of wrong-sided blocks for all peripheral nerve block types, both upper and lower extremity. And the rate at the institution at that time was 0.5 per 10,000. But they did note that the incidence of wrong-sided blocks decreased from all peripheral nerve block types, both upper and lower extremity, after implementation of the change in policy. So what are some of the risk factors for this procedure? So first, we'll focus on some of the patient and procedural contributors. So I think bilateral symptoms and pathology are very, very important to note. I think the most recent one that we had at HSS a few months ago involved a patient that was supposed to have an adductor canal block on one surgical site, but the surgeon was also supposed to do an injection, a steroid injection on the opposite side. And unfortunately, the block got placed on the side of the injection versus on the side that was supposed to have the total knee replacement. So that definitely plays a role. I think altered mental status and language barriers, where the patient is unable to identify what the correct part of the body or where the correct procedure site is. Things like time pressure, emergency cases, complex anatomy position, multiple procedures in one encounter, et cetera, et cetera. So as I was reading up about this, and I saw this interesting article in Anesthesiology News in 2021, and they pointed out that, even how we drape our patients for the procedure may contribute, right? As you can see in session B, they had marked out the correct side for the patient for the block. But then after they prepped and draped the patient, their drape actually covers the site that they're working on, their site marking. So that's something to take into consideration. Now let's talk about the second risk factors, human and system factors. So we'll have things like cognitive biases, interruptions and distractions, inadequate handoffs, poor documentation, lack of standardization, and not following your protocol or your checklist. And again, I selected this one case that was published as in RAPM. This was a case that was presented at the 2023 ASRA Spring meeting. And this was from a group in the UK, and they unfortunately had a wrong-sided upper extremity block. And I think this was a nice thing to read, because you could see how they went through what they kind of determined, how did we end up having this wrong-sided block? So their reasoning was a problem. A nerve block was performed on the contralateral sides of planned surgery. Why? We forgot to stop before you block. So they forgot the timeout process. The second reason, we were distracted by the ergonomic setup. A third reason, the ultrasound machine was prepared and ready for the incorrect side. They needed the ultrasound machine for IV access on the opposite side. And then after they placed the IV, they then moved up the arm and placed the block on the incorrect side. So kind of evaluating these processes and reporting them are important. So next, I wanted to talk about the Joint Commission, the principles of their universal protocol. So they emphasize that wrong person, wrong site, and wrong procedure surgery can and must be prevented. They're encouraging using multiple complementary strategies, active involvement, use of effective methods of communication among all members of the procedure team. And then lastly, consistent implementation of a standardized protocol. So what's important in our pre-procedure verification checklists? So things that we want to include are a correct patient identification, your correct procedure and site confirmation, valid and specific consent, clear site marking, and overall a multidisciplinary agreement. So timeouts are actually one of the elements of the Joint Commission Universal Protocol for preventing wrong site, wrong procedure, and wrong person surgery. And that has been effective. The Joint Commission has implemented this since July 1st, 2024. And specifically at my institution at HSS, we mandated a timeout process before peripheral nerve blocks in 2003. And then in 2007, we made 2 more changes in our policy to mitigate the risk. And again, this is very similar to the World Health Organization's checklist, which is their 19-point checklist, which they want people to use for any procedure. So that's not limited to anesthesia. Specifically, it's for all surgical or invasive procedures. So now let's focus on site marking and timeout. What are the steps that you should be taking? So for best practices, you want to mark the site with the patient involved if possible. Obviously, we talked about language barriers and patients might have dementia who may not be able to participate in the process. We also want to use standardized, unambiguous marking. I'll give one example. At one institution that I worked in, the surgeon's initials were NO. And of course, if he puts NO on the site, it might look to like the staff as like, do not block that side. So it's very important that things like that are kind of clarified ahead of time. perform a block-specific timeout, and reconfirm patient procedure side and imaging orientation. I did want to talk a little bit about this stop before you go session, which was implemented in the UK in 2021. And the 3 phases of the prep, stop, and block are underlined and in different colors. And the time points at which to hand over and hand back the tray are shown, as well as emphasis that there's a delay to immediate insertion of block after stop moment. So again, as you go along when you're in the stop section, if you're not able to complete the stop section to move to the block section, they want you to go back up to the prep section on the top. So additional evidence-based prevention strategies are to have standardized checklists, the stop before you block, or some sort of verification process. Some people use ultrasound with site laterality, labeling, but the most important thing is empowering team members to speak up. If somebody sees that you're on the wrong side, to stop the incorrect block before it happens. Speaking again about, this is another study that was published by Dr. Ligori and some members of our group about the checklist process, but talking specifically about HSS, we did develop a restrictive needle technique where nurses provide the needle to the practitioner right before the block is placed. And again, this change was made in 2007. And how this, what happens now is the nurse actually takes the block needle out and will connect the block needle to your block solution and will hand it to you after your time out. And the nurse is also supposed to stand by your side as you insert the block needle into the patient. And then after that, the nurse can leave. So what are some system level contributors and how can we improve them? So why do our systems fail? Obviously, we have production pressure, inconsistent workflows or not following the workflows, staffing or handoff variability, and then poor reporting culture can contribute. And then reducing the susceptibility to error, things we can do is standardizing our block workflows, having dedicated block areas with the same block nurse or block team who sort of does it day in and day out, having some mandatory documentation fields, and simulation, and also training the team on how this process works. And of course, regular audits and feedback to make sure that we are doing the timeout before placing a block. Now, if a wrong-sided block occurs, what should you be doing? So the immediate response is you're going to stop the procedure. You'll assess your patient for safety and harm. You're obviously going to notify surgical and anesthesia and even hospital leadership. You'll inform the patient honestly, and you're going to document clearly. And then for reporting and learning, so after the event, we'll complete incident reporting. New York City actually uses, or New York State, New York State uses a New York patient occurrence reporting system called NY Ports. So every adverse event is supposed to be reported to them. So I went on their website a few days ago, and they had data up to date for 2023. So you can see highlighted, I highlighted wrong side, wrong patient, wrong procedure. And you can see in 2023, there were 125 incidents that were reported to NY Ports in 2023. So this made up 4.3% of all adverse events in New York State. In comparison, the most common was death and serious injury, and that was 50% of the that was reported to NY Ports, and that was about 1,400 patients. So again, these occurrences are relatively few and far between. Next thing after the event, you'll do a root cause analysis, you share lesson learned, and then you want to implement some system changes. So I think about 4 to 5 months ago, we did, unfortunately, again, had a wrong-sided block at HSS. And one system change that we did implement was sending out an email now to every month to everybody in the anesthesia team, reminding them as of such and such date, it's been a couple of 100 or 200 or 300 days since the wrong site block. Think safely, work safely, follow these steps, speak up. Again, this is a way to kind of remind our team to keep this in the back of our minds, especially since we are a high volume block institution and we do many blocks multiple times a day. So what are some of the key takeaways that I want to share? Wrong-sided blocks are preventable. Risk increases with complexity and ambiguity. Standardization and teamwork and communication increases patient safety. And of course, how we respond matters as much as prevention. So Raj and Rakesh, again, thank you guys for the opportunity. I really, really appreciate it.
That was wonderful, Uchenna. Thank you so much. The wrong side block thing is kind of like a thing I'm paranoid about. And you mentioned the draping. I missed it. One of the things that we struggle with the most is just putting the ultrasound on the right side of the patient.
Yes.
And that can be such a weird, strong cue that we've had near misses because of just somebody put the ultrasound on the wrong side of the bed. It's weird. Those little things can cause us to become victims to just behavioral problems.
Because we're all on autopilot a lot of times.
A lot of times. Yeah.
And I always like to say I personally had a wrong-sided block very early as in my attendinghood. I was 6 months in. I think that kind of scared me a lot. I've become a little bit of since then I've become a little bit paranoid about it. But again, placing the ultrasound machine on the opposite side, there's so many little systems, things that you want to do. You want to check yourself at all times, but also having team members that kind of watch you and kind of guide you along the way is very important.
Rakesh, do you guys mark the block site? And if you do, what do you use to mark it? I mean, what do you put on there?
We write block on the block, and we write block on both anterior, like if it's bilateral, or like if it is anterior and posterior, we write block both sides.
Yeah.
So we turn the patient, we are able to see the backside of it as well.
Yeah. I think block is a good word to put for marking. Initials just get confusing because the surgeons are putting initials, and nobody can tell anybody's initials from each other. So, any other thoughts, Rakesh?
No, we often we often are pressurized to work in a fast-paced environment, and many a times either it's the work pressure or the complacency that that person will do a good job kind of an attitude, which often leads to wrong events or adverse events. So what do you think is the most vulnerable part of the block procedure when you try to do when these things happen? What do you think is the systems level failure?
I think not having that communication, because the nurse should be your backup, right? If I'm on the wrong side, I should have another person that indicates to me that I'm on the wrong side. So I think not having that's the factor that I think is the most important one that could be prevented, because you're not doing that time out by yourself. You're doing it with a nurse or a resident or wherever you are. There's somebody else who you're supposed to be doing it with. So if you don't catch it, that person is supposed to sort of catch that for you. So I think that's one of the areas that I think is most vulnerable. Like I said, not everybody does site marking. The surgeons do mark at HSS, but we personally don't mark the site at HSS. It's not part of our protocol. We kind of follow the surgeon's mark at our lead. So to me, that's not what it is. I think having that nurse, and that's why we gave the power to the nurse by handing her the needle and having her be that last stop to hand you needle that you're on the right side before you place that in.
Yeah. Well, thank you so much for joining us on this World Day. Really appreciate your insights. And we are going to move on to our next speaker. You're welcome to join us on the YouTube live stream.